And we have next session on Diabetic Coronary Artery Disease, chaired by Dr. Sethu Raman sir, MD in Internal Medicine, Trichy. Sir, I'd like to call upon to the dais. Our very first speaker would be Dr. J.M. Ravichandran Edwin sir, MD, DM, FACC, FESC, FSCAI, Professor and Head of the Department of Cardiology, President Tansei Tirunelveli, 34 years of unembellished medical service in Tamil Nadu Medical Department, 23 years as an interventional cardiologist, would be now talking about ACS in diabetes and how it differs. Here you go, sir.
At the outset, I thank Professor Dr. Arul Raj, the great, legendary physician, for having given me this unique opportunity to talk on ACS in diabetes, how different it presents. Scope of the problem: diabetes is one of the most chronic diseases in the world. It affects an estimated 463 million adults in 2019. The mounting incidence and prevalence of type 2 diabetes, driven by increasing population of age, obesity and physical inactivity, compounded with the high global burden, as thus the increasing longevity of the patients with the disease. The diabetes mellitus will of course affect more than 700 million persons, that is 10.9% of the global adult population by 2045. Diabetes mellitus involves insufficient production of insulin or failure to respond appropriately to insulin, resulting in hyperglycemia. Type 2 diabetes is characterized by insulin resistance and relative insulin deficiency, that is more than 90% of the diabetes mellitus cases, whereas type 1 diabetes is defined by absolute insulin deficiency. According to American Diabetes Association, the diagnostic criteria for diabetes mellitus is 1. The fasting plasma glucose if it is more than 126 milligram, or 2-hour plasma glucose that is more than 200 milligram during an oral glucose tolerance test, or the glycosylated hemoglobin if it is more than 6.5%, or in a patient with classic symptoms of hyperglycemia or hyperglycemia crisis, a random plasma glucose of more than 200 milligram per deciliter is sufficient. Cardiovascular disease, as you all know, remains the principal comorbid condition and primary contributor to mortality in patients with diabetes, usually in the form of coronary artery disease, but also in the incremental risk associated with diabetes for cerebrovascular disease, peripheral vascular disease, heart failure and atrial fibrillation. The atherosclerotic vascular disease, that is patients with diabetes have a 2 to 4-fold increased risk of coronary heart disease, that is cardiovascular mortality, all-cause mortality, cardiovascular hospitalization compared to those without diabetes mellitus. Diabetes entails an increased risk of myocardial infarction, as you all know. Across the spectrum of acute coronary syndrome events in which diabetes may affect more than 1 in 3 patients, those with diabetes, they have worst cardiovascular disease outcome. Despite all improvements in the outcomes during the past several decades for ACS patients with and without diabetes, the gradient of risk associated with diabetes mellitus still persists. So from the graph, you may note the death from any cause, death from cardiovascular disease, death from coronary artery disease, hospitalization for cardiovascular disease, all are increasing compared to the patients without diabetes. Here also, the cardiovascular disease with diabetes, the bleed and CVA are more compared with patients without diabetes. The risk stratification. We classify it as 3 categories very high risk and moderate risk. Very high risk patients with diabetes and established cardiovascular disease or other target organ damage, or three or more major risk factors, or early onset of type 1 diabetes of long duration, that is more than 10 years. High risk patients include patients with diabetes more than 10 years without target organ damage plus any other additional risk factor. Moderate risk includes young patients, that is type 1 diabetes less than 35 years of age, or type 2 diabetes age less than 50 years with diabetes duration less than 10 years without other risk factors. So this is the coronary artery disease in a patient with diabetes. Patient comes with insulin resistance, thereby leading on to increased fibrinogen, thereby leading on to increased wall stress, thereby leading on to abnormal metabolics. So this is a picture from a optical coherence tomography. That is, you can see the plaque rupture. That is, it's a soft plaque with thin cap, and that is a large plaque burden with increased macrophages. This is a vulnerable plaque. So here is the picture how the pathogenesis goes. It starts with atherogenesis, goes for atherosclerotic progression, thereby leading on to atherothrombosis. The principal vascular perturbations linked to hyperglycemia include endothelial vasomotor dysfunction. The endothelium, you all know, is the largest endocrine organ in the body. So it is the endothelial vasomotor dysfunction and vascular effects of advanced glycation in products and adverse effects of circulating free fatty acids, increased systemic inflammation and prothrombotic state. The myriad mechanisms contributing to endothelial dysfunction include abnormal nitric oxide biology, increased circulating endothelin and angiotensin II, and reduced prostacyclin, all of which contribute to perturbations in the regulation of blood flow. High triglyceride level, low level of HDL, that is an increased small dense low density lipoprotein particles, characterized diabetic dyslipidemia, which will contribute to aggravated atherosclerosis, the deadly triad, and perturbations in the coagulation and fibrinolytic pathway and in platelet biology add to the prothrombotic risk in diabetes mellitus. These abnormalities include increased circulating free fatty acids, factor 8, and von Willebrand factor and plasminogen activator inhibitor 1, and decreased level of antithrombin 3 and protein C. Increased systemic inflammation accompanies diabetes associated with increased oxidative stress and accumulation of AGE. So, the screening of diabetes in acute coronary syndrome patients, 1/3 of the acute coronary syndrome patients have previously diagnosed diabetes. Moreover, many patients present with ACS even as the first complication of diabetes. Previously undetected diabetes is also common, affecting up to additional 20 to 25% of ACS patients. Therefore, all patients with ACS events warrant screening for diabetes. Given the stress hyperglycemia associated with ACS events that may confound blood glucose testing, screening should extend beyond assessment of fasting blood glucose and include HbA1c testing. So, insulin administration and glucose control. Here, 2 trials were there, as you all know. One is GIK therapy, that is intensive glucose control during acute MI. That is, this trial compared, that is 20,201 patients. This trial is called as CREATE ECLA GIK trial. They conduct the trial in ST elevation MI, randomized to GIK therapy versus usual care of accumulating 1980 mortality events, demonstrating clearly it shows no benefit of GIK therapy compared with usual care. Then another trial is DIGAMI, DIGAMI trial. Here, this also showed the intensive blood glucose control is not useful in acute MI with acute MI with diabetes. So often misinterpreted as a trial of intensive glucose control, this study provided the basis of ACCF and AHA guidelines recommendations for intensive glucose control in the management of ACS in 2004. However, in the absence of evidence of beneficial effects of intensive glucose control in ACS population, a series of trials in the ICU settings, that is, they demonstrated no significant benefit for the most part and increased mortality with intensive glucose control with IV insulin. More recently, the AHA guidelines and ESC guidelines have omitted recommendations with regard to targeted glucose control during the management of ACS events. So, this is a class 2A recommendation, that is use of insulin-based regimen to achieve and maintain glucose level less than 180 milligram deciliter while avoiding hypoglycemia for hospitalized patients with acute coronary syndrome with either a complicated or uncomplicated course is reasonable. So here the management of hyperglycemia, it is recommended to measure glycemic status at initial evaluation in patients and perform frequent monitoring in patients with non-diabetes or hyperglycemia. That is, it should be around 200 milligram. In patients with metformin or SGLT2 receptor, the renal function should be carefully monitored for at least 3 days after coronary angiography. Glucose lowering therapy should be considered in ACS patients with glucose level more than 180 milligram, while episodes of hypoglycemia should be avoided, that is less than 70 milligram should be avoided. Less stringent glucose control should be considered in the acute phase in patients with more advanced cardiovascular disease. Antiplatelet medication. ACS patients with or without diabetes should receive aspirin. Various studies have tested the potential for more than intensive antiplatelet therapies to provide particular benefit to ACS patients with diabetes. So the P2Y12 receptor antagonists, that is incremental evidence, showed the clopidogrel, prasugrel and ticagrelor to aspirin therapy in the treatment of ACS has been demonstrated in randomized clinical trial. In the CURE trial, the clopidogrel showed positive response in addition to if it is added to aspirin. And in another trial, Triton TIMI 38 trial, they showed good response for prasugrel. In diabetes patients, prasugrel did not lead to significant increase in major bleeding. In Triology ACS trial, treatment with clopidogrel or prasugrel found no significant differences. In Plateau trial, as you all know, which enrolled 18,000 patients, more than 18,000 patients with ACS with or without ST segment elevation, ticagrelor is significantly reduced the primary composite outcome of death from vascular causes, MI and stroke. In aggregate, these observations support the incremental benefits of more potent antiplatelet treatment added to aspirin therapy in patients with diabetes, with superiority of both prasugrel and ticagrelor over clopidogrel. The P2Y12 receptor antagonist should be considered in the routine clinical management of patients with diabetes and acute coronary syndrome. Then renin-angiotensin-aldosterone antagonists. Here you all know the ACE inhibitors have several favorable effects in ACS that may particularly benefit patients with diabetes. The usage of ARB, 2 trials were conducted, Optimal and Valiant, and here the losartan did not show superiority over ACE inhibitor and valsartan did not show any superiority over ACE inhibitors. But ARBs should be considered as an alternative only for patients intolerant for ACE inhibitors. Another trial is EPHISIS, that is eplerenone post-acute myocardial infarction heart failure efficacy and survival study. Here it showed the mineralocorticoid aldosterone antagonists eplerenone to placebo added to optimal therapy in a population of 6,632 patients with MI with decreased ejection fraction, that is less than 40%, who had either clinical heart failure or in the absence of manifest heart failure. The treatment with eplerenone compared with placebo reduced the risk of cardiovascular disease death by 17%. On the basis of this trial, the use of aldosterone antagonist for patients with diabetes with reduced ejection fraction after MI is recommended in ACS patient. If the creatinine is low, that is less than 2 milligram, and if there is no hyperkalemia. Then beta blockers. The biological effects that support the incremental evidence of beta blockers in the setting of diabetes include the restoration of sympathovagal balance in patients with diabetes with autonomic neuropathy and decreasing fatty acid metabolism within the myocardium, reducing myocardial oxygen demand. Therefore, all patients with ACS should receive beta blockers independent of their diabetic mellitus status in the absence of contraindications. The favorable effects of beta blockers were for carvedilol and labetalol. So, the AC inhibitor should be given as a class 1 indication for indefinitely for patients recovering from MI with diabetes unless contraindicated. Long-term aldosterone receptor antagonist should be prescribed for patients with MI without significant renal dysfunction. Then, primary invasive strategy for non-ST segment elevation acute coronary syndrome. Here in randomized trials comparing primary invasive versus non-invasive strategy, the subsets of patients with diabetes derived similar or greater benefits than those without diabetes mellitus associated with primary invasive management strategy. Although mortality and reinfection rates were still higher in the groups with diabetes mellitus in both treatment arms. Primary reperfusion therapy for ST segment elevation MI. Here it showed patients with diabetes and STEMI should undergo reperfusion therapy in the absence of contraindications, preferentially with the strategy of primary PCI whenever it is available. Then coronary revascularization considerations. In patients with diabetes, the anatomical pattern of coronary artery disease influences the prognosis and the response to revascularization. Angiographic studies show that patients with diabetes are more likely to have left main and multivessel disease and diffuse small vessel disease. Current guidelines recommend medical treatment including anti-ischemic drug first line of treatment for patients with diabetes and stable coronary artery disease. For patients requiring revascularization, the optimal strategy remains controversial. The optimal medical therapy versus revascularization in diabetes, here it showed in several trials, that is Barry trial, the bypass angiography revascularization is the CABG is better than, that is in patients with more extensive coronary artery disease and proven ischemia, CABG may be preferred. The ischemia trial, it showed that here the results did not differ between patients with or without diabetes. Here it showed at 6 months the cumulative event rate was 5.3% in the invasive strategy and 3.4% in the conservative strategy. But at 5 years, the cumulative event rate was 16.4% and 18.2%. The coronary artery, the cardiac trial showed that in multivessel coronary artery disease, the CABG is definitely better than the PCI. With respect to lesion complexity according to syntax score, this is another trial. Only patients with diabetes with more complex disease had a treatment benefit of CABG. In Freedom trial also, it showed the CABG is better than PCI in multivessel disease in a patient with diabetes. So take home message, cardiovascular disease remains the principal comorbid condition and primary contributor to mortality in patients with diabetes, usually in the form of coronary artery disease. All patients with ACS events warrant screening for diabetes. Given the stress hyperglycemia associated with ACS events that may confound blood glucose testing, screening should extend beyond assessment of fasting blood glucose that include HbA1c assessment. The P2Y12 receptor antagonist should be considered in the routine clinical management of patients with diabetes and ACS with superiority of both prasugrel and ticagrelor over clopidogrel. Routine use of AC inhibitors for patients with diabetes is a level 1A recommendation in ACS. The use of aldosterone antagonists for patients with diabetes with reduced ejection fraction after MI is recommended in ACS except in patients with impaired kidney function or hyperkalemia. All patients with ACS should receive beta blockers. Trials of primary PCI suggest greater benefit in patients than in those without diabetes, with primary PCI proving superior to thrombolytics in these patients. In 2019 ESC guidelines on diabetes, pre-diabetes and cardiovascular disease recommend CABG over PCI in patients with diabetes with triple vessel disease. Both CABG and PCI receive a class 1 recommendation for patients with two vessel disease with proximal LAD stenosis or left main stenosis with low complexity. Thank you, one and all.
Thank you, sir. Thank you very much, Dr. Edwin, for the wonderful speech on the relationship between the diabetes and cardiology, coronary artery disease. Since it is a global burden, you have highly enlightened the aspirin plus other platelets, the use of other platelets and mineralocorticoid antagonists and beta blockers, and also insisted on the multivessel disease, the treatment of choice is CABG rather than PCI. Your points are very well taken, sir. Thank you for the wonderful and elaborate lecture. Thank you very much.
Talk. And our next speaker will be Dr. A. Bavatarni ma'am, Senior Consultant Diabetologist, Erode State Coordinator, IMA Diabetes Course, Joint Secretary, DIPSI and TNRSSIDI. Ma'am would be talking about diabetes and CAD. Are we dealing with the human volcano? Here you go, ma'am.
Thank you, Ma. Respected chairperson, all my dear colleagues, very good afternoon. My immense thanks goes to Dr. Aarti and Dr. Arul Raj for giving me this wonderful opportunity to stand in front of you. Now my topic is, of course, sir has made my thing easy by saying so many things, but still, we just want to know what happens if both are present together. See, if you take the Indian scenario, we have about 537 million diabetics and it's spiraling out of control, and 1 in 10 people have diabetes, and half of them do not know that they are diabetic, remain undiagnosed, and the overall diabetes prevalence is increasing, and the changeover from pre-diabetes diabetes is very fast in our country compared to the other countries.